Welcome back to PBH 275, Injury Prevention and Control. This week's module is going to cover the topics of drowning and poisoning. Now we're only going to talk about poisoning a little bit in this module because the predominant source of poisoning in the deaths in the United States has to do with overdoses, predominantly due to the opioid epidemic. And that's going to be covered separately in the film you're going to watch entitled Understanding the Opioid Epidemic, and there will also be a discussion board post covering that film. But there are other types of poisonings that we will discuss in this module. The first part of this module will cover the injury topic of drowning. We will define what drowning is, and then go over some of the statistics about it, including some of the health disparities that are seen, how some people are more susceptible to drowning incidents, fatal and non-fatal. We'll talk about risk factors and preventive strategies. And then for poisoning, we will briefly talk about overdoses and why they should be considered injuries rather than illnesses. And then we'll talk about, outside of overdoses, probably the other major category of poisoning injuries that happen in the United States, and that will be childhood poisoning, and some methods for preventing this. So let's start with drowning. What is drowning? Drowning is a submersion incident that occurs with a liquid. Otherwise, it would be classified as suffocation. I've done a lot of injury epidemiology in places in the eastern United States where we used to have incidents of people engaging in farm activities who were walking on top of piles of grain inside silos or bins, and they would fall through the grain because there would be an air pocket underneath it, and they would become suffocated underneath it, engulfed. And some people would call that, drowning in grain, and talk about what a horrible way it was to die. And it was, and it is, but that's technically not drowning because that's more suffocation or engulfment. The World Health Organization defines drowning as the process of experiencing respiratory impairment from submersion or immersion in a liquid. And that's the difference, because with liquids, what happens is if you're submerged under liquid, after a while, you can't hold your breath forever. Eventually, you have to at least try to breathe. And if you try to breathe when you're submerged in liquid, what happens is that liquid gets deep into your lungs, deep into the gas exchange regions where things like grain can't get that far. So you can actually get deprived of oxygen even quicker in a liquid environment as opposed to a non-liquid environment. So that's how the WHO defines drowning. Furthermore, the WHO classifies drowning based on outcomes, and there's three major outcomes that they look at. Death, which is a clear and obvious measurable outcome. No morbidity, meaning that following the drowning or submersion event, they're resuscitated, their lungs are cleared out, and they more or less get back all the function they had before the event. And then morbidity, which is further categorized into four different categories. These include moderate disability or moderately disabled, severely disabled, meaning that there are some functions that are lost due to loss of oxygen for key tissues for whatever interval that the drowning and submersion event occurred. A vegetative state or coma, which means that only a very low level of brain or brainstem activity remains, enough to sort of power organs and basic function, but that, some of the higher order functions such as communication or movement are completely lost. And then finally, brain death, which is essentially death because at this point all brain activity is lost, and you cannot live without brain activity unless you're on a life support system, and that's once you're off the life support system, you die pretty quickly. So really that probably should be classified as death, but that's not the way the WHO does it. What's interesting is if you look at the worldwide data, there's a lot of times when children will drown because maybe they don't fully know how to swim yet, or they get into a situation that exceeds where they're not supervised, and they get into a situation that exceeds their capabilities. So fatal child drowning is unfortunately common, all throughout the world, but for every fatal child drowning, another 5 children receive emergency department care. And if you have to go to an emergency department for a submersion or drowning event, there's a pretty good chance that there's going to be some level of disability that occurs afterwards, because our tissues are so very sensitive to loss of oxygen, even for just a short period of time. And when we look at children ages 0 to 4, there's even more require emergency department care. It's estimated for every 1 death in this age category, there are 7 children who have to be treated in the emergency department for a drowning or immersion event. So, as those WHO definitions just reminded us, drowning is not always fatal. In fact, a lot of times it's non-fatal, but non-fatal drownings can result in no impairment, some impairment, or significant impairment. Current estimates from the Centers for Disease Control and Prevention are that about 20% of near drownings in the United States, people that suffer these will have permanent neurological damage. And so about 1 out of every 5 person who has a non-fatal drowning event has permanent neurological damage afterward. And that's because the neurological tissues, particularly the brain and central nervous system, are so dependent on oxygen. You cut off oxygen even for just a couple of minutes, and irreversible damage can occur. And that is often what happens. The current estimate from CDC is that over 40% of drowning victims who go to emergency departments for treatment, the extent of their injuries are severe enough that they require hospitalization or transfer to higher levels of further skilled care. They might need hyperbaric oxygen or surgery or something else more advanced. Now, if you compare that to other forms of unintentional injury, it's estimated that about 6% of people who come to an emergency department for treatment of unintentional injuries wind up having to be hospitalized or receiving more advanced or skilled care. 6% versus more than 40%. This should give you an idea of how dangerous drowning events are and how they are much more likely to lead to severe, lifelong impairments. Dr. Cinnamon Dixon, in the Week 1 lecture, talks a little bit about drowning as a worldwide cause of death. And according to data from the World Health Organization, approximately 300,000 drowning deaths occur worldwide every year, including the most recent year for which they had data. The National Safety Council estimates that drowning is the 3rd leading cause of unintentional injury death worldwide. The WHO data also shows that it's disproportionately occurring in lower and middle income countries. That's where 92% of all drowning deaths occur. Some of this might be due to geography. A lot of these countries are located in low-lying areas with lots of water and where boat and fishing and other related trades are very important. It also has to do with infrastructure, and a lot of lower and middle income countries are not always going to have some of the safeguards you need at places like public pools and beaches and things like that. If you do a computation of how many drownings are happening per hour based on this data, you find that it's 34 people die from drowning every hour across the globe. Let's return once again to the CDC WSCAR's 10 leading causes of injury death in the United States table. What we see is, for the year 2024, drowning was the 9th overall leading cause of injury death here in the United States, with 4,540 documented cases of death by drowning. What you see from the red circles is that it's a lot more prevalent in early years than it is in later years. It's among the top 5 leading causes of injury death for everybody from ages 1 to 14. And then it stays in the top 10 causes of injury death up until ages 55 and over, at which point it falls out of the top 10. This will be familiar to all of you now, but there are some profound gender identity related disparities in drowning deaths, as there are with many other sources of injury death here in the United States. Those who identify as male represent 76% of drowning deaths. Now, some possible factors for this include more exposure to aquatic environments, overestimation of swimming ability, which is sometimes coded with gender identity, higher risk taking and being encouraged to take more risk, which is often also coded with gender identity, and higher alcohol use, which we clearly know happens more among those who identify as male versus female. There's also, as I showed you before, children under the age of 15 years often overestimate their swimming ability, underestimate danger, or just find themselves in situations that they can't get out of and end up being victims of drowning. There are also higher rates among certain racial and ethnic categories, such as American Indian and Alaska Native populations, Hawaii Native and Pacific Islander populations, and black populations when we compare it to white populations. I will go later on into some of the reasons why swimming in particular. There are some historical reasons rooted in racism and many other factors that have sort of impeded African American children from learning to swim at the same rate as their white counterparts. We'll get into that later on. And then living in rural or non-metro areas versus metro areas. This probably has something to do with people who live in rural, non-metro areas have more access to things like ponds and lakes and other environments where certainly recreational swimming and boating and fishing and things like that can happen. And anytime you're exposed to aquatic environments to a greater degree, your risk of drowning goes up by a greater degree as well. There are also profound and troubling disparities in rates of drowning death based on race and ethnicity characteristics. And we particularly see this among African American communities. Really, I mean, and this article on injury prevention kind of goes into a lot of the history of this, but Hispanic and black children are more likely to report an inability to swim compared to their white counterparts. And inability to swim is unfortunately one of the primary risk factors for subsequent drowning death or severe injury from drowning. And when you look at the statistics underneath it, you see that for African American children 5 to 14 years have a fatal drowning rate that's almost 3 times that of white children in that same age category. If we look at African American children aged 5 to 19, specifically using swimming pools, they are 5.5 times more likely to drown in swimming pools compared to their white age-matched counterparts. And we look at just the band of 11 to 12-year-old, that difference between African American and white children is 10 times greater. And there are some historical reasons why minority children have reported inability to swim, and a lot of it is based on racism, and it really extends back to the beginning of the 20th century. Throughout the mid to early 1900s, and especially in the southern United States, there were actually limitations on who could use municipal pools and even beaches that were like along lakes and oceans. There were a lot of these that were actually closed off to African Americans and other minorities. And so you might not realize this, but that was actually one of the frontiers of the battle for civil rights in the middle of the 20th century. It wasn't. You might be more familiar with some of the battles for integration that occurred in buses and at lunch counters, but attempts to integrate swimming pools and beaches was also a major frontier in the fight for civil rights and equality. And what unfortunately happened in a lot of these areas, particularly when we talk about municipal or city-owned swimming pools, is that yes, there were attempts to integrate, and there was pushback. And what a lot of cities did was they sort of took a cowardly approach, in that they didn't really want to see trouble happen. So they actually started closing their swimming pools to everybody. This was kind of an era when the city-owned swimming pools started to disappear because they just took the cowardly approach of we don't want any trouble, and having rather than having these battles of integration occur, we'll just close the pool. And so what happened is that a lot of people, particularly, I mean, even African American and other minority people, including children, were starting to get access, and then suddenly it was taken away because these pools started closing. And what also happened from that point on is that pools became increasingly privatized. You know, when municipal pools started closing, what happened is that neighborhoods and homeowners associations started operating pools. They would usually have it in their neighborhood with a gate code. And what's happened in this case is that, and you can guess this has happened a lot here in the U.S., where in these private HOA owned community owned pools, there's sometimes confrontations that occur, you know, where if somebody sees somebody they perceive that doesn't belong in their neighborhood, they confront them about what they're doing in the pool. And so it's there's still a lot of racism, there's still a lot of classism, but this whole thing has kind of conspired to sort of cut off a lot of opportunities for children, particularly minority children, to have access to safe swimming areas and really learn how to swim. And we are still seeing some of the sad outcomes of that, which is that minority children, particularly African American children, often don't know how to swim or not taught how to swim, and they have drowning rates that are much higher than their white counterparts. This is a major public health and social justice issue that we need to be addressing as hard as we can, because people are still dying from this. So, even in the present day, racism and classism, which has led to some poor policy choices, is a major risk factor for drowning. Another major risk factor is aquatic exposure. If you live in a neighborhood with a pool, or you have a pool, or you live close to a lake or an ocean or a beach, that is a risk factor for drowning. What's a protective factor is having swim lessons. This makes it less likely that you're going to drown and makes you a more confident swimmer. Of course, that confidence can be a detriment if it causes you to overestimate your abilities, but for the most part, statistics show that the more practice you have and the more lessons you have, this generally leads to a reduced risk of drowning. There was an interesting research study done by Dr. Jennifer Farr, one of our UNLV public health faculty, which showed an interesting and inverse correlation between parental fear of drowning and children learning to swim. It was like where as parents had higher fear of drowning, it was less likely their children would learn to swim, because I guess parents were very concerned about even wanting their children to be in an aquatic environment to learn, because they assumed that there was danger there, and they didn't want them to even do the practice and what it took to learn. And this has some important implications if you think about it, based on what we talked about in the last slide. You know, particularly for minority children, you know, the parents and caregivers of minority children, they might have never learned to swim because, you know, historical racism and economic factors meant that they were never given opportunities to learn to swim. And so they have a great fear of their children ever being exposed to aquatic environments, even if it's to learn to swim. And so this kind of propagates the problem of, you know, minority children not ever learning and not ever getting that protective factor, which is associated with learning to swim and becoming confident in your swimming abilities. It should come as no surprise that barriers, you know, are another important protective factor, and lack of barriers around, for example, a swimming pool is a risk factor. What might surprise you is the magnitude of this, though. These two pictures we have an isolation fence that completely goes around a pool and isolates it from the rest of the yard. In this case, it's a backyard swimming pool. And that reduces a child's risk of drowning by 83% compared to what a lot of houses here in Las Vegas have, which is a property line fencing where, yes, nobody can, nobody can, it's not easy to get over the fence into the property and access the pool, but the problem with the property line fencing is that once you're in the backyard of the house, you have basically unfettered access to the pool. And especially for children, it only takes just a very brief moment of being unsupervised for them to get into a pool and quickly start to drown. So just having a complete isolation fence around a pool reduces risk of drowning by 83% compared to traditional property line fencing. For children, one of the major risk factors for drowning is lack of close supervision, and as we'll talk about in a little bit more detail shortly, it does not take very long at all for a child who's not supervised to get into a dangerous situation with water, and it doesn't have to be very much water at all. We'll get into that again shortly. Location can be a risk factor. For children aged 1 to 4 years, the place where they are most likely to drown is in home pools. Though also other areas in the home, such as toilets and bathtubs, are other common areas of drowning, but home pools are most common in that particular age range. As children get older and get into adulthood, the danger tends to come from natural water settings, including lakes, rivers, oceans. That increases with age. Over half of fatal and non-fatal drownings in people over the age of 15 occur in what we call open water. This would be places like Lake Mead or bays and estuaries of the Pacific or Atlantic Oceans or the oceans themselves. A major risk factor is, particularly when we talk about boating-related fatalities, is the failure to use life jackets or personal flotation devices. Well over 80% of drowning fatalities occur to people who are on boats when they're not wearing a life jacket. The study from Cummings and colleagues from 2011 estimated that 88% of drowning fatalities due to boating incidents, the people who died were not wearing a life jacket. And that's been consistently seen in the subsequent years as well. And for those 12% of people who were wearing a life jacket and were still drowning fatalities, a lot of times this was people who were wearing a life jacket but not wearing it properly, or they were people who maybe were in a high-speed boating collision and they suffered some other severe injuries that they still were classified as drowning deaths, but there were some mitigating factors. But the point here is that personal flotation devices or life jackets are incredibly helpful in, if you're out boating and something happens and you wind up in the water, where you can keep your head above water until you can be rescued. They work. Use them every time. For adolescents, teenagers, and adults, alcohol use is another major risk factor for drowning. It's estimated by the CDC that alcohol is involved in up to 70% of all deaths associated with all forms of water recreation, and about 20% of all reported boating deaths, and almost 25% of all emergency department visits that have to do with water recreation. Seizure disorders are another major risk factor. Seizures can occur when they occur. They can cause people to drown, even in just as small of bodies of water as a bathtub. Certainly, if you have uncontrolled seizure disorders, that's a major risk factor for drowning, not just in bathtubs, but certainly in pools and lakes and oceans. And this is where close supervision is probably necessary to ensure that if you have a seizure while you're in a water situation, that you can get pulled out before critical lack of oxygen occurs. And as I touched on earlier, parental behaviors and beliefs are another major risk factor. Again, going back to some of Dr. Jennifer Farr's research, children swim significantly more and have a much higher protective factor against drowning if their parents or caregivers encourage them to swim, or if they have members of their family that know how to swim and swim with them. If the parents or caregivers are not afraid of their children drowning or not afraid of drowning themselves. And again, there's a lot of major implications for this about why we have such a profound racial and ethnic disparity in rates and risks of drowning. Drowning is a quick and silent killer with a rapid onset. It doesn't take very long at all from the time of first immersion until severe neurological damage can occur. In the time that it takes to get a towel, as little as 10 seconds, a child can become submerged. If in just 10 seconds of not having their activity monitored. In the time it takes to answer a phone, maybe just engage in a little bit of a business talk. So about 2 minutes, a child that's gotten submerged can begin to lose consciousness. In the time that it takes to answer the front door and maybe again engage in some face-to-face business in as little as 4 minutes, a submerged child can sustain permanent brain damage or die. So again, from the time of first breathing in water until permanent neurological damage due to central nervous system deprivation of oxygen occurs is a very short interval. It does not take very much water for an immersion or submersion incident to occur, particularly with small children. Children can drown in as little as 1 inch or 2.5 centimeters of water. And it's not just pools and bathtubs and toilets that are of concern. On an average year in the US, 25 children will drown just in simple buckets. The current estimate from the CDC is that 78% of infant drowning deaths occur in bathtubs or buckets. There are products called infant bathtub seats. They have little suction cups on them. The intention of the infant bathtub seats or rings is that an infant can be held upright by these devices in the tub so that the parent or caregiver can wash them on all sides because, infants can get dirty on all sides very quickly. Well, the Consumer Product Safety Commission has had to release warnings about infant bathtub seats and rings because what happens a lot of times is they will get the suction cups on them usually don't work all that well. They can get unstuck very easily, and when they get unstuck, the whole device can kind of, start free floating in the water and turn to the side, and then the infant that's inside it will get turned to the side and pulled underwater. So there have been calls to ban these products. They've not been banned yet by the Consumer Product Safety Commission, but a lot of warnings have been released about them. And if you're going to be a caregiver that's using one of these, they do require supervision at all times because even if you just turn your back for a minute or two, that if the thing becomes unsuctioned and turns over with the infant in it, then that's a drowning and submersion incident. What's also been shown in research studies, including this one from Morangiello and colleagues in 2013, is that parents tend to underestimate the level of supervision that their children need, and they tend to overestimate their child's swimming ability. Even when child swimming instruction includes a parental education component, there still tends to be an overestimation of how well a child can actually do in an aquatic environment. And as you would guess, that's a risk factor for drowning. When we look at the available data from here in Clark County, Nevada, courtesy of the Southern Nevada Health District, we see some interesting trends. One of which is the total number of submersion incidents that is reported to the Southern Nevada Health District has varied from 26 to 46 in a given year. Now, a lot of submersion incidents are never reported because they happen at home and the child is removed from the water, they are given resuscitation, their breathing passages are cleared, and they seem to have no impairment, and it never gets recorded as an official statistic. But for the ones that have been reported, the vast majority of them happen in children between the ages of newborn to 4 years old. Most of them happen in pools, with the largest percentage of these being in residential pools versus public pools, because as we talked about before, public pools are not as prevalent as they used to be for reasons that have to do with liability, racism, many other factors. If you want to know how many fatal drownings happen amongst children under the age of 14, well, for many years it's never been more than 10, and for the last 2 years that data is available, it's marked as less than 5 with an asterisk, partly because in some cases, it's never been definitively determined that drowning and submersion was the actual cause of death. But the point is, yeah, every single one of these that happens is a tragedy, but thankfully, not a lot of them have been happening in Clark County, Nevada in recent years. I will provide some greater detail on drowning injury prevention and mitigation in some subsequent slides, but first I want to introduce you to one of the frameworks that is most commonly used when we're talking about drowning injury prevention and mitigation, and it's called the chain of survival. What you might notice immediately when you look at this chain of survival is that it is color-coded in such a way that lines up very well with primary, secondary, and tertiary prevention, where the green link is we prevent the drowning or submersion or immersion event from occurring in the first place. Again, that would be the primary level. Then we get into the yellow links, which is the secondary prevention. This would be the injury phase of a Haddon matrix, if you prefer to think of it that way. Where one of the most important things you can do as part of the chain of survival is to recognize signs of distress. Usually if somebody's in an aquatic environment and they start to get into a situation that's dangerous and they feel that they're in danger, they will make some recognizable gestures, usually with waving, yelling if they can when their head is above water. There are ways to recognize these signs and then to act on them. And again, you have to recognize true signs of distress versus just, sort of playing around, as often kids and adolescents will do in pools, where they might do things that look like signs of distress but are actually not. But yeah, you recognize signs of distress and then you call for help or ask someone to call for help. The next most important thing in the sort of the secondary level or the middle of the chain of survival is to provide some type of flotation device, like a life ring or something like that, because if a person can keep their head above water, even if they're struggling, that's one of the most important things, because the longer their head is underwater, the more water they're aspirating, the more oxygen deprivation that's occurring, the more likely that neurological and other tissue damage is occurring. So if we can prevent that for as long as possible with the use of a life ring or other flotation aid, that's really important. So you try to deploy the flotation aid to the person struggling as quickly as possible. And then the next link, again, still in the secondary realm, is to remove the person from water, but only when it's safe to do so. This is something very important to keep in mind if you're going to ever work in the realm of safety and health in any role, be it a lifeguard, a safety and health person in a factory, or anything like that. If you're going to assist somebody, you need to make sure that you have the training and the gear and the knowledge and everything you need before you go there. If you jump into the water to help somebody and you're not a particularly strong swimmer and you're not equipped with your own flotation device or life ring or something like that, what often happens is that you are not able to help, and in fact you get stuck in the same situation, and now there are two people who need rescuing instead of just one. So that's very important to keep in mind if you ever are going to try to assist in a situation like this. Provide for your own health and well-being as well, because that way you'll actually be able to provide assistance and you won't just make a bad situation worse. And then finally, at the end, the red link, where a person is getting medical attention, they're getting the water out of their lungs to try to get oxygen back to tissues as quickly as possible through initial and then more advanced medical care. That's definitely in a tertiary element, because the drowning and submersion incident did occur and now medical care is necessary. But you add all these up and it's called the chain of survival. Because the risk of drowning is so great in the very earliest stages of life, and it doesn't take very much water or very much time at all for a drowning incident to occur, a lot of prevention tips are aimed toward caregivers and people who are parents or caregivers for very small children. Some of these tips include the following. Keep a child within arm's length if there's any type of water environment nearby. Put away distractions whenever it's bath time or swim time or waiting pool time, or anytime when a child is in an environment with water. That there needs to be some undivided attention at that time because, again, it does not take very long for an immersion or submersion incident to occur. At the conclusion of bath time or play time or whatever other activities are being done with water contained in tubs, buckets, or containers, or wading pools, empty those containers out immediately and store them upside down and out of reach when not in use. The reason why you want to store them upside down is particularly in areas where precipitation events can occur and they're outdoors. They can refill back up with water relatively quickly and become a hazard again. And this can also help prevent the harborage of mosquitoes and other insects that depend on stagnant water environments. There are unfortunately a lot of children that drown just in simple toilets. So until children sort of develop to an age where they can understand what the toilet is and what's the purpose of the toilet and the dangers of the toilet, you should probably keep toilet lids closed until children get to that developmental age. You can even consider toilet seat locks, which are a relatively new development to prevent drowning or submersion from occurring in a toilet. It's generally a good idea until children get to a certain developmental age to keep the doors to bathrooms and laundry rooms closed. As we stated before, never leave a child alone in the bathtub, even if they're in like one of those rings or other things that's supposed to keep them upright. Those things can and do fail, and it doesn't take very long for a child to get submerged. It's also important to learn cardiopulmonary resuscitation, or CPR, and infant and child CPR is different than the CPR that many of us learned from the American Red Cross for like adults. So these are all prevention tips directed toward caregivers. One of the best prevention strategies is to ensure that children from a very young age have swim lessons. And in fact, the current recommendations from the American Academy of Pediatrics, which is supported by other public health and injury control organizations as well, is that these swimming lessons can start as young as between the ages of 1 to 4. Now, of course, with swimming lessons, we have to confront the fact that access to pools and swimming lessons has been kept away from minority children in particular for many decades now, and this is a problem that we need to address head on and ensure that there's equality of opportunity and that some of the parental and caregiver fears that are rooted in racism and inequality are also dealt with. But what is undeniably shown is that this is a tremendously big protective factor against drowning risk. Back in 2010, when the American Academy of Pediatrics released their policy statement for prevention of drowning, they included some epidemiologic research in that prevention policy statement, one of which was a case control study in 1 to 4-year-olds. And what they found was that drowning victims were less likely than matched controls, significantly less likely to have had formal swimming instruction. The difference was 3% versus 26%. So just a huge, incredibly statistically significant difference in drowning risk based on having had formal swimming instruction, even at this very young age. They also found that participation in formal swimming lessons was associated with an 88% reduction in the risk of drowning in the 1 to 4-year-old children category. And this was important foundational research because there used to be a belief that children couldn't really learn how to swim until after about age 4, that before that they were just not cognitively developed enough to even understand what they were doing or get the significance of what they're doing. But it turns out that yes, even very young children, even as young as the age of 1, some children before they even know how to walk can be taught how to swim. So the data I showed you on the last slide was from 2010. Well, in the year 2019, the American Academy of Pediatrics officially updated their recommendations, and these updated recommendations is one of the articles you were assigned to read in this week's module. So under the AAP's updated recommendations was that swim lessons should be considered for all children, including those ages 1 to 4. They didn't go as far as to recommend that all children ages 1 to 4 receive swimming lessons, just that they should be considered, because for very young children there there are some who are just not going to be ready for this at that age, and that parents should decide whether to enroll an individual child in swim lessons based on the child's frequency of exposure to water. Because again, that's one of the #1 risk factors for risk of drowning is how often are you exposed to water or aquatic environments. This decision on whether or not to enroll a very young child in swim lessons also should be based on that child's emotional maturity, on any physical and cognitive limitations they might have, and also certain health concerns related to swimming pools. Some children do not react very well to chlorine or chloramines or some of the other disinfectant chemicals that are often used in swimming pools, so that can certainly be a factor. And that even if you give swimming lessons to children starting at a very young age, that all parents and caregivers need to understand that swim lessons cannot drown-proof any child, that supervision and barriers remain essential. The Safe Kids campaign here in Clark County, Nevada, publishes a document called the ABC and Ds of Drowning Prevention, Simple Rules to Stay Safe Around Water. A lot of times we remember things a little bit better when we have an acronym. And so the acronym here, A, B, C, and D, consists of A is adult supervision, B means barriers for your pool, C means classes, not just swim lessons, but also cardiopulmonary resuscitation classes, and D equals devices. These would include personal flotation devices or life jackets, and also rescue tools, whether it's life rings or any other things that are appropriate for children. They can be quickly deployed to a child that's having a submersion or immersion incident, so they can be brought out quickly before a lot of water is breathed in and a lot of oxygen deprivation occurs. Now we will address the second topic of this module, which is poisoning. Since 2013, poisoning has been the leading cause of injury death in the United States, and it's not even close between it and second place. This is why we're going to address this in this injury prevention and control class. You can see, in the most recent year for which we have data, there were more than 75,000 unintentional poisonings, largely but not entirely driven by the opioid epidemic. The next leading cause of injury death was unintentional falls, with more than 27,000 fewer deaths than by unintentional poisoning. As for the reason why unintentional poisonings are now the leading cause of injury death, most of it is due to overdoses, and these overdoses stem both directly and indirectly from the opioid epidemic. I'm not going to talk about this a lot in this module because you have an entire film, Understanding the Opioid Epidemic, that you're going to have to watch this week. And then there's also a discussion board assignment associated with that film, where I have some specific questions that I want you to address after you've watched the film. That's going to cover a lot, including the pathway that a lot of people go on, where they start with a prescription for a painkiller due to an injury of some sort, but then through a chain of events, they end up addicted to heroin and other street drugs. This is covered in the film, and you're gonna deal with this in your discussion board assignment. So I won't talk a lot about this. Just have a few other things to say about this. One is that usually overdoses and other poisonings are considered unintentional injury deaths. But sometimes with overdoses in particular, it's not always possible to determine the intent after a person has died. But for the most part, what we know is that almost all of these are unintentional. And there's a lot of ways you can get an unintentional fatal overdose poisoning. One of those would be you miscalibrate a dose, you end up injecting or ingesting more than you thought just because you miscalibrated or calculated wrong. Particularly when you're dealing with street drugs, these can have variable strength and purity. You might not always be getting what you think you're getting, and a lot of times these drugs will be laced with other drugs, such as fentanyl, that maybe your body is not prepared to deal with, and that's how a lot of overdose deaths occurs, is by the variable strength and purity, and particularly when fentanyl is used as a lacing drug for things such as heroin, that leads to a lot of overdose deaths. Another very tragic reason why a lot of people have fatal overdoses is that when people get addicted to a substance, such as an opioid, and they try to rehabilitate, they they taper off, they go into a program, they do something like that, and that's a good thing to do. But there's a real danger when you're doing this, that if you have a relapse, it can often prove to be fatal, because what often happens if you have a moment where you, during your rehabilitation, where you decide, oh, I've got to go back and have another hit. And what happens with a lot of people is their tolerance decreases during that time when they're off the drug, and so when they have a relapse and they go back and try to take the same dose they took before that used to be their maintenance dose, well, unfortunately, with the reduced tolerance, that maintenance dose, after a prolonged period of being away from it, can become a fatal dose. And that's how a lot of unintentional overdose deaths occur. There also are some overdoses and other types of poisonings where it's intentionally done, where somebody is seeking to die by suicide using overdose or poisoning as the mechanism. Usually these are either classified as unintentional or unclassified unless there's some clear reason to believe that the person intended to die by suicide, such as they leave a note or they've said some things to friends in the days or weeks leading up to it. For the most part, these are classified as unintentional injury deaths. While overdose deaths remain, by a large margin, the leading cause of injury death in the United States, we have at least reached a point where it looks like it might have peaked and is starting to decline a little bit. Overdose deaths in the U.S. peaked in the year 2021, and then they plateaued in 2022. They started to decline in 2023 and decline a little bit more in 2024. But this is still a major public health problem, and we should not celebrate at this time. We have a long way to go if we want to rein in this major injury issue and this major public health issue. I assigned the editorial from Pelosi on this week's module as well because I wanted to deal head on with the question of overdoses and why they are considered injuries rather than illnesses. This probably surprises a lot of people when they come into an injury prevention and control course that we talk about overdoses as, as an injury that's amenable to the same types of public health preventions as other types of injuries, including other types of poisonings. And really, the risk factors for overdoses and the preventive strategies for them, they fit well within traditional injury paradigms, such as the Haddon matrix and the Haddon countermeasures, just like other types of poisonings do. And other types of poisonings are not often labeled as illnesses or diseases. They're like childhood poisonings. Those are considered injuries, and overdoses should be as well. I think a lot of the past resistance to labeling overdoses as injuries and sort of trying to apply public health knowledge and tools to their prevention has been because, well, often when we're dealing with overdoses, we're talking about an injury that's largely self-inflicted. Plus, especially when we get out of the realm of prescription drugs and into, for example, street drugs, often the actions that lead to overdoses are considered, well, are illegal in a lot of times. And that's definitely something that separates us from other injury types and injury risk factors. There has been a perception in our culture that drug overdoses are a social problem and should be dealt with as a social problem rather than a public health problem. And also because a lot of people still feel that the exposures that lead to overdoses are things that are crimes or sins or a stigma, depending on your jurisdiction and your own ethics and values. But we as public health minded people and public health professionals we don't need to go in that direction, I don't think. We need to just try to protect public health and public well-being as much as we can. And if we think about this a little bit, I mean, a lot of injury things that we deal with have some elements of self-selected risk. There are types of motor vehicles that are more dangerous than others by any measure you want to do. For example, motorcycles are always going to be a greater injury risk for their driver than a traditional sedan or truck would be. And yet we don't stigmatize people who choose to ride motorcycles. What we do is we just try to create the safest environment we can for people who opt for that, or for bicycles, or for people who walk as their form of transportation. Not everyone can be encased in 2 tons of metal at all times when they're in transit. So we have to we have to be careful as and be fair in our public health, and not try to apply some biases and stigmas to what is a problem, and just address the problems in our society as they come up. Another factor is that overdoses are like many other injury and public health issues, and that there are risk factors and vulnerable populations. And these vulnerable populations should be tracked so that in the event that a new greater hazard comes into the community, these people can be reached quickly before something bad and fatal happens. Examples of this would be in almost any community you go to, there's going to be a population of people who use Adderall, either they have a prescription for it or they're using it off prescription, and there'll be people who use heroin. Well, sometimes street heroin and street versions of Adderall will be laced with fentanyl. And so if a batch of heroin or Adderall that's laced with fentanyl starts reaching a community, that's as public health people, we want to get out there as quickly as possible to the people who might receive this and let them know that, hey, this batch is different. This has got something in it that it's not going to be the same as the stuff that you've taken before, and this is, you could die from this, and we can save a lot of lives and prevent a lot of misery. Just like we do with any other outbreaks of disease or injury or anything else. We can treat overdoses the same way, but it requires tracking, and it requires effort, and it requires being non-judgmental. Plus, public health professionals can share what's been learned from approaches that address other types of poisonings in order to reduce overdose poisonings. We can talk about the strengths and limitations of behavioral approaches that we've learned from, for example, childhood poisoning prevention, or behavioral approaches for parents and caregivers. We can also talk about the strengths and limitations of engineered or agent modifying approaches. Admittedly, these would probably only apply to prescription drugs, because street or illicit drugs don't necessarily aren't made in traditional factories with sort of traditional quality control and things like that. But this became an issue when Purdue Pharma, the company that manufactures OxyContin, they've tried a few different engineering approaches to sort of put coatings and other things on the OxyContin pills to sort of prevent the sort of illicit off-label use that had been happening. Of course, a lot of these have limitations, these agent modifying approaches. There are ways to overcome them, and people are creative. But yeah, this kind of knowledge can be shared from one type of poisoning prevention to another. Just like with many other types of injuries, public health can offer evidence-based and non-judgmental approaches to overdose prevention, which can minimize the risk of injury when primary preventions fail. And yeah, it would be better for society and for everyone, individually and collectively, if primary strategies always worked. If we could have a society where nobody became addicted to dangerous substances that were capable of causing fatal overdoses. I mean, that's upstream. That's what we should always be working toward. But the truth is, as public health minded people, we have to realize that some people will be vulnerable to these types of injuries, and so we have to think a little bit more downstream as well. And in this case, public health often has been leading the way with some interventions and ideas that are evidence-based, They work well to prevent overdose-related deaths, but sometimes these strategies have faced resistance in communities, because of moral or religious reasons. But these are things that they do work, and we need to advocate for them, because we can't just rely on primary preventions all the time. These include clean needle exchange programs, and you're probably thinking, well, clean needle exchange programs are mostly for the prevention of HIV and other bloodborne infectious diseases, and that is correct. That is their primary reason for them. They also prevent overdoses, though, because a lot of times when you reuse a needle, there will be trace amounts of the previous drug in there that maybe somebody else took, and it's a drug that you would react very badly to. So there's an overdose prevention element to clean needle exchange programs as well, which is why it's important to have them in places where drug use via needles occurs. Withdrawal management interventions, including medication-assisted therapies. These can help reduce some of the painful withdrawal symptoms that often lead people to not get off of a drug because the withdrawal is just so painful, the dope sickness it's called. But withdrawal management interventions that involve medication and supervised taking of medications can and do make a huge difference. A very controversial thing that's come out in the last few years, but that again has shown great evidence of preventing overdose injuries, is supervised injection sites. These have been tried in places like Philadelphia and San Francisco, where you actually have a site where people can go to self-medicate, to administer their own prescription or even illicit drugs. And these sites will usually have support available to people who want to quit or who want to go into withdrawal management interventions. And they also have medical people standing by in the event that an overdose occurs to quickly be able to treat the person so that they don't die of an overdose. So supervised injection sites work. I mean, probably the most obvious reason right now why they're not really getting widespread acceptance is because the activities that take place at supervised injection sites, particularly when they involve non-prescription or illicit drugs, are activities that are still technically illegal under federal law. And so therefore there can be jurisdictional issues about why this city or this town is allowing people to shoot up illicit drugs when that would be criminalized outside of that realm of that supervised injection site. So they work, but there's still some political hurdles to clear before they become a little more widespread. What also helps a lot is training not just people who take drugs, but people in the community, people who might interact with people who take drugs and who might be prone to overdose. And that's training in the use of Narcan, or naloxone hydrochloride, an opioid antagonist that with one little intranasal spray injection can quickly reverse the effects of an acute overdose crisis. And Narcan is now available over the counter without a prescription, and I would encourage all of us who have the potential to interact with people who might be in overdose crisis to carry unexpired Narcan with you at all times, because you just never know. But anyways, these are all evidence-based public health interventions that can be applied to overdoses, just like there's evidence-based public health can be applied to lots of other types of injuries. And so we should. So that's all I'm going to say in this module about opioids and drug poisoning. Let's shift our focus now to another major area of poisoning, which is childhood poisoning, and the things we do to try to prevent childhood poisonings. This is obviously not as big of a public health threat as the opioid epidemic or unintentional overdoses, but it's still a relatively significant public health threat. The current estimate is that every day in the United States, approximately 300 children will be treated in an emergency department for a poisoning incident, and 2 of them will die. So how do we go about preventing childhood poisonings? We can start with education, again, the first of the 3 or 4 E's of injury prevention. We know that education is effective for caregivers because Just like with drowning, I mean, caregivers or parents are the ones who have a lot of say as to what kind of environment their children are in and what the profile of the hazards are that children will be surrounded by. So educating caregivers is always going to be a good thing. There's not a lot of evidence that education of children on how to avoid poisonous substances is particularly effective. Sort of like I talked about with drowning, children might not necessarily have the cognitive abilities, particularly when they're very young, to understand what is a danger to them and what is not. That's why having the caregivers around them educated is probably even more important. There could be some role for childhood education, and we'll talk about one of the most famous childhood poisoning prevention education campaigns of all time, which is the Mr. Yuck campaign. That little green yuck face you see there on the right of the slide, this was developed and introduced to the US back in 1975. It was actually during the Super Bowl of 1975. There was a 60-second public service announcement that aired during one of the ad breaks of the Super Bowl. They introduced this character, Mr. Yuck. And Mr. Yuck is mean, Mr. Yuck is green. And the point of the PSA was that if you see the Mr. Yuck face on a bottle of household cleaner or any other products in your house, that you as a child should be scared of that, because what's in this, even if it looks attractive, even if it looks tasty, what's in this package could harm you, so stay away. So Mr. Yuck became a cultural phenomenon, and as I'll talk about a little bit more in the next slide, there's limitations to the education in children and what kind of impact that can have on poisoning prevention, but what Mr. Yuck did was change the culture in a very profound way, and that's what I'm going to get into next. The intention of the Mr. Yuck campaign was to educate kids, and honestly to scare kids. They actually had focus groups of children, back in the early 70s when they were trying to come up with a campaign, and they tried to find out what would be the most scary combination of image and voiceover and everything like that to be maximally scary to a kid. And that's what they did for the Mr. Yuck campaign. That's a type of research that I wonder if that would pass through an institutional review board in the modern era, but in the 70s they were able to do that. There's still not necessarily a lot of great evidence that the Mr. Yuck campaign actually changed the behavior of children, that children actually saw the sticker and were deterred from consuming the product within it. We still don't have a lot of evidence that occurred. What actually occurred, though, was something just as important, maybe even more important, though, which is that these stickers were available at local health departments and stores and other places, and parents and caregivers, they wanted to get the stickers, and so they did. But then what happened is parents and caregivers took a closer look at all the chemicals that were in their house, and yeah, they would identify the ones that would need a Mr. Yuck sticker, but they were not just putting the stickers on and assuming that, okay, everything's fine. They were going and taking it further and making sure that anything that was toxic enough to get a Mr. Yuck sticker should also be put out of reach of their children. That there should be that, again, it kind of worked as a parent and caregiver education, and it helps them to create a safer environment for children so that childhood poisonings would be greatly reduced, just because things that were marked as dangerous were now being put out of reach of children. They were being put on higher shelves, or they were being sold in child-resistant packaging, again, as part of a consumer demand. This caregiver education on poison hazards that was brought by this campaign made a tremendous difference. And not only that, this caregiver education sort of created a demand for a lot of other products that didn't really exist at the time, like child-resistant locks for cabinets, such as medicine cabinets. Many of you probably grew up in an era where there were probably some cabinets in the bathroom that you didn't yet have the cognitive ability to know the three things you had to do to open up that cabinet. And as a very young child, it's probably very frustrating to you. Well, those products didn't exist until the Mr. Yuck campaign created a demand for them, for child-resistant locks. There was also a demand for safer products. The thought that, well, if this incredibly dangerous ammonia compound that I'm using for cleaning the kitchen, could there be a safer alternative? So if my child did get into it, they're not going to be as at severe of a risk for poisoning. So safer products resulted. And there was also a demand to establish a national poison control hotline, which for a long time, when people still had landlines in their houses, there would be the National Poison Control Center number positioned very close to the phone. It's still a good number to have even today, where you can get instant advice if a child or someone else has taken something. So yeah, not a lot of evidence that the education actually changed the behavior of children, but it changed the behavior of parents and caregivers. And that made all the difference. Childhood poisonings went way down after this campaign really got some traction. For childhood poisoning prevention, it is necessarily going to be a large focus on changing the environment and creating a safer environment for children. And it's usually going to be upon parents and caregivers to create that safer environment. Some ways to do this include the following. Keep all medicines and toxic products in a place where children cannot get to them. They can be in a locked cabinet, they can be placed well out of reach, or a combination of both. The thing to consider with this is that as children get more advanced and more developed, they can sometimes figure out how to overcome a lock, or they can figure out how to climb up to a high shelf that they couldn't reach before. So if you have to have a dangerous product in the household and you're relying on locks or being out of reach, just make sure that you periodically reconsider your strategies based on the level of development of the child. Child-resistant caps on medicines have not always been a thing. They were developed in the mid-1970s, again, in response to some of the market pressures I talked about earlier. And they're a great device. When a child-resistant cap is on, most children below a certain age, below about 5 or 6, simply cannot get it off. And so therefore they can't get to the dangerous medicines within it. Now, most child-resistant caps have a second setting for people that don't have children or small children in the house, and where you can turn it around and use the other end of the cap as more or less a conventional screw cap. Now, if you have small children in the household, please ensure that child-resistant caps are kept in place in the child-resistant locked mode, not in the non-protective screw top mode. It is critical to read all labels carefully before giving any medicine to children. Their needs can be a lot less than ours, and their bodies are a lot smaller, and they metabolize medicines in a different way, so read very carefully before you attempt to do that. The best thing you can do for childhood poisoning prevention would be a form of elimination, or the top of the hierarchy of controls, which would be if you don't need it. If it's an old medicine nobody's taking anymore, an old household cleaner's been replaced by something newer and safer, get rid of it. As long as it remains in the house, it remains a potential hazard, even if it's in a locked cabinet. But if it's not in the house at all, it's not a hazard. Let's talk briefly about another type of poisoning that sometimes happens in a little bit more so in like adolescent and early teenage years children, and that's where children will copy a viral challenge they see online and wind up becoming poisoned. It's important to have honest and age-appropriate discussions with kids about the dangers of viral challenges that they might see online and might want to try to imitate. In the last few years, there have been several kids and young adults that wind up having to go to the emergency department because of severe pulmonary edema caused by ingesting large amounts of cinnamon at once. That was called the Cinnamon Challenge. There also were some adolescents who got very sick and some who even died after deliberately filming themselves eating Tide Pods. That was called the Tide Pod Challenge. The Tide Pods are depicted here. They also represent a possible poisoning hazard for very young children because they look appealing. So like some of the other things we were talking about before, we're keeping things that look appealing but that could be poisonous out of the reach of very small children. But anyways, back to sort of adolescence and early teens and viral challenges. Again, it's just communication is really important. If you are a caregiver of somebody in this age group, whether it's a child, someone you watch over, and a niece or nephew or anybody like that, just let them know that they can come talk to you if they're about what they've seen online. They don't, and let them know that they don't have to do something just because they saw it online. And while while this doesn't result in a lot of deaths every year, there's always a lot of the deaths are always tragic because it usually happens to somebody very young. But then also there's a lot of judgment that comes from society whenever somebody's child is severely injured or even killed when they try to replicate a viral challenge they saw online. So, and we don't know what the next viral challenge is going to be. That's why communication is probably the most important thing to prevent this type of unique poisoning event. As we get near the end of this module, I want to talk about some natural poisoning threats that need to not be forgotten about and considered. There are some plants that are often found in gardens or even in indoor settings that can be poisonous if ingested. I'm going to describe. There's some pictures here, and from left to right, these are what we're talking about. These include the oleander. Oleander is found a lot in many gardens in southern Nevada, both certainly many decorative gardens. It's a drought-tolerant plant with big, colorful flowers on it. The calla lily, the tiger lily, the holly. The big red berries of the holly can look appealing and even tasty, but they're not to be ingested. And then the caladium. There's a lot of different varieties and colors of caladium. They tend to kind of look like this, where they'll be kind of pale colored with big, bright colored veins on them. These are if any of these plants are present, any places where children are present, they need to be closely monitored to ensure that children don't try to ingest any of them. There are some other outdoor plants that could certainly be poisonous if ingested, but are also poisonous on skin contact. And these would include poison ivy, poison oak, and poison sumac. If you're a parent or caregiver or planning on being a parent or caregiver someday, and you take kids in outdoor settings, it's important to know if poison ivy, oak, and sumac are native to some of the areas you're going to go, and if so, to recognize these so that children can be kept away from them. In the bottom row, the first two pictures are the cow parsnip and the giant hogweed. These both look a little bit more like the more benign Queen Anne's lace, a very common wildflower throughout North America. But both the cow parsnip and the giant hogweed, if an adult or a child rubs against them, it can create local burns and blistering of the skin, and it can even have some more dangerous systemic effects as well. So exposure to anything any cow parsnip or giant hogweed or even Queen Anne's lace, because it looks so much like these others, it's probably good to keep children away from those. And here in the southwestern U.S., we also have something called the poodle dog bush. It's that purple plant in the lower right. This is often present in the scarred areas where wildfires have occurred. And it's a very attractive looking plant, but like the cow parsnip and giant hogweed, it produces this resin that can blister the skin and also be a systemic poison. So children need to be kept away from that one as well. In final summary now, drowning is still the 9th leading cause of injury death in the United States, and it's a major killer worldwide. But there are effective prevention strategies at the primary, secondary, and tertiary level if we just apply them. Poisoning is still by far the leading cause of injury death in the United States, as both a direct and indirect result of the opioid epidemic. While the progress since 2021 is hopeful, it's still not enough, and we need to keep working on this issue. One of the great success stories in public health is the way that we've reduced childhood poisonings. And this is something that whenever we get frustrated with the pace of progress and other things in public health, we can look back on that and remember that, yeah, it is possible to turn the tide in a major injury issue. So that's it for this week. Let me know if you have any questions or comments. Thank you for your attention today.